Nystagmus surgery, does it really work? We're discussing key concepts for planning nystagmus surgery. First of all, we should establish the correct diagnosis. Make sure it's really nystagmus and only nystagmus. There's no sensory deficit and there's no other diagnosis. We should examine the head position properly, examine the strabismus properly, and examine the eyes. Examine again and again. Don't rely on one examination. Retinal image slip degrades visual acuity and causes a perception of blurring. Patients with nystagmus are variably aware of these problems, but congenital nystagmus patients do not report oculopsia and may not notice degradation of image quality, especially if they have afferent visual deficit. We have, in general, 3 modalities of treatment: optical, pharmacological, and surgical. Our aims in surgery is to correct the anomalous head posture, improve the torticollis, and improve the oscillation, which in turn would improve the waveform, periodicity, increase foveation time, broaden needle point, which results in faster visual recognition and overall better visual acuity. When is surgery recommended? At preschool years, to optimize the visual function and alleviate cosmetic defect prior to the critical developmental period, where significant changes in amplitude and directionality and location of the null zone occur as the patient grows up. For tips, we should observe for at least 5 minutes to make sure it's not periodic alternating nystagmus. We should repeat more than once the orthoptic examination and take a careful history or video recording of the head position, providing a dynamic target to observe the head tilt. Dr. Höltel says that 100% of infantile nystagmus have a point where the nystagmus is the least. 40% is usually straight ahead, less commonly chin down, like in albinism. We should perform the surgery on the fixing eye, then neutralize any residual angle with surgery on the non-fixing eye. Our surgical options in general include shifting the null zone, doing Kistenbaum and Anderson procedures, Cupper's artificial divergent surgeries, Deloso tenotomies with reattachment, or retroequatorial recession, or is there a roll of buttocks at the end? Kistenbaum works by recess and resect in each eye to observe the gaze palsy in the preferred direction, shifting the null point centrally and reducing the head turn. Anderson works the same but with recessions only. So we move the eye toward the face turn or chin position, recessing the muscle working opposite to the direction of the face turn and resecting the muscles working toward the face turn. For example, for a right face turn, the nystagmus null point is in the left gaze. We should move the eye to the right, recessing the right medial rectus and left lateral rectus, and resecting the right lateral rectus and left medial rectus. How do we do this? We put a prism on the fixing eye and do an R&R for that, and then a prism on the non-fixing eye and neutralize the residual angle with R&R. This is the recommended dosage based on the Park's original 5, 6, 7, 8 rule, and then the augmented parts with addition of 1 millimeter or 20, 40, 60% to the formula. For a patient with a vertical head posture, we also do the same. For a chin down position, we move the eyes down, recessing the superior rectus and weakening the inferior oblique. For a nystagmus with a head tilt, we transpose the eyes to the side of the head tilt and the vertical muscles opposite to the head tilt. This is also the recommended surgical plan from Dr. Kushner to encyclorotate the eye and excyclorotate the eye. For nystagmus with strabismus, it might be tricky because surgery should be performed on the fixing eye also, with any residual heterotropia performed on the non-fixing eye. We should operate on all horizontal recti. For a small deviation, recession and tenotomy could work. For a larger deviation, recession and resection would work. Taking into consideration the strabismus, we add whatever angle results from the first surgery to the other eye. So R&R for an XT patient, for example, with a right face turn, might make the XT worse. For a multiplanar head posture, we should identify which component is the largest and plan to treat it. And see if we can correct the second most important component with a muscle transposition. For example, if we plan a horizontal Kiston bomb for a face turn, we treat the chin up or down by transposing the horizontal recti. We should consider recessions to spare the muscle from resections, consider obliques for tilt to spare the recti. For a patient, an abusing patient, BMR can work to create XT, which is called artificial divergence surgery, described by Coppers. We can test it in the clinic by doing by having the patient with a base-out prism, small base-out prism with a minus lens. Have the patient wait and see if there is improvement. If there is improvement, the patient might do well with a BMR. Spielman has 12 millimeter recession, or recommends 12 millimeter recession, while Kushner, while Hertel does 5 to 7 millimeter. For nystagmus compensation syndrome, BMR would work, plus or minus posterior fixation suture by Coppers. For a patient with no abnormal head position and no strabismus, tenotomy and reattachment of all horizontal recti have been described, and it works by theory as a proprioceptive deafferentation. Also, retroequatorial recession might also work. In cases of albinism, idiopathic infantile nystagmus, and periodic alternating nystagmus. For monocular blindness, Kiston bomb surgery in the seeing eye, which might not be very convincing to the family. Is there any role for Botox at the end? Botox might significantly reduce the nystagmus during 3 or 2 months in the beginning. But the risk is ophthalmoparesis might reduce useful eye movements, and the long-term tolerance of nystagmus is limited, of Botox is limited by the diplopia and ptosis. At the end, does it really work? We should have first, as we said, proper diagnosis to plan any surgical intervention. We should compare our expectation and to the patient versus reality. Even if the nystagmus were eliminated completely, the integrity of the afferent system, optic nerve, retina, and brain disease, and age-related timing of the surgery limit the visual acuity in any patient. We should always individualize the procedure according to the patient findings, and research has begun to answer the questions of whether eye muscle surgery improves nystagmus and visual function, but a multitude of questions still remain. Thank you.